All right, let's jump right into this explainer. Today, we're looking at a massive paradigm shift in how we handle Alzheimer's disease. For decades, we've essentially viewed Alzheimer's as a purely clinical syndrome, just this inevitable cognitive decline. But right now, we are in the midst of a total revolution, transitioning to treating it as a biologically defined and actively treatable condition. This is an advanced postgraduate review, and we're going to unpack the science driving this incredible transformation.
Here is our roadmap for today. We'll be covering atypical clinical variants, pathophysiology, genetic drivers, biomarkers, immunotherapies, and finally, area safety. Starting off with Section 1, Atypical Alzheimer's Clinical Variants. Now, when we think of Alzheimer's, we almost always picture memory loss, right? But here's the thing, about 20% of patients actually present with something else entirely. Alzheimer's can totally masquerade as other neurological conditions. Take a look at these 4 non-amnestic presentations. You've got logopenic PPA, where the main struggle for years is just word finding and repetition. Or maybe posterior cortical atrophy, which hits visual processing. Then there's the frontal or dysexecutive variant causing behavioral issues, and even cortical basal syndrome, bringing on asymmetric, akinetic, rigid, dystonic movement problems. It's wild to think these can happen long before memory ever starts to fail.
Moving on to Section 2, Pathophysiology and Secretase Kinetics.
So what's actually happening under the hood to drive this? It's all about this sequential cleavage cascade. It starts with APP, the amyloid precursor protein. In a diseased state, APP gets cleaved first by beta secretase, and then, step 2, gamma secretase comes in, which intimately involves the presenilin 1 protein. This exact sequence is the problem. It creates a major imbalance, dumping out toxic A-beta 42 peptides instead of the harmless P3 peptides you'd normally get from a healthy pathway. And that A-beta 42 buildup, that is the primary spark for cellular damage.
But here's where it gets really fascinating. The retromer complex, specifically the VPS35 component. The retromer complex is this conserved membrane-associated protein complex that basically acts like a microscopic traffic cop, routing APP away from endosomes. Why is that a big deal? Well, endosomes are exactly where APP gets sliced up into that toxic beta amyloid we just talked about. We've actually found deficiencies in VPS35 and Alzheimer's hippocampi, meaning if we can stabilize this complex, we might just have a massive therapeutic target for the future.
Next up is Section 3, Genetic Drivers and Risk Factors.
Let's look at the actual genetic blueprints. This table breaks it down cleanly. Up top, you have the rare deterministic mutations in APP, PSN1, and PSN2. These are the ones driving highly penetrant early-onset familial Alzheimer's. We're talking striking patients in their 40s or 50s. Below that, we have the potent risk modifiers. APOE4 is the big one for sporadic Alzheimer's. It acts as a dose-dependent modifier that wrecks A-beta clearance. If a patient is homozygous for E4, their risk skyrockets by 10 to 15 times, no joke. Then you have genes like TREM2, a microglial receptor. Lose function there, and your risk goes up 4-fold, which just goes to show how massively innate immunity and microglial clearance impact this disease.
But hey, genetics aren't just about risk. Sometimes they give us incredible resilience. Just think about this for a second. Nature actually threw us a lifeline with a rare genetic phenomenon called the Christchurch mutation, a point mutation in the ApoE3 allele. Carriers of this mutation actually seem protected against tau aggregation and dementia, even if their brains are literally full of amyloid plaques. It is an absolutely mind-blowing natural defense mechanism that researchers are studying super closely right now.
All right, Section 4, Biomarkers, PET, and fluid.
So we know why these proteins build up, but how do we accurately spot them in living patients? We are in the middle of a total revolution in fluid biomarkers. A decreased A-beta 42 to 40 ratio mixed with elevated phosphorylated tau, like p-tau 181 or 217, completely changes the game for diagnosis. And the best part? We're detecting these in blood plasma now, not just CSF. No tissue biopsy required. Just keep in mind, you gotta be precise. Medical comorbidities like a reduced creatinine clearance can actually skew those blood concentrations and potentially give you borderline false results. And for a more visual approach, just look at how this brings the pathology to life. In the top row, you've got amyloid PET showing widespread tracer retention. But check out that middle row. That is tau PET using 18F fluorotaucipir, which binds specifically to Alzheimer's neural fibrillary tangles. Notice how asymmetric it is, and then the bottom row shows FDG PET highlighting decreased synaptic activity or hypometabolism. What's super cool here is that the pattern of hypometabolism tracks almost perfectly with the tau deposition, rather than the more scattered amyloid plaques. Moving right along to Section 5, monoclonal immunotherapies. Armed with these definitive biological diagnoses, we can finally bring out the big guns, disease-modifying therapies. Here are the two fully FDA-approved monoclonal antibodies that aggressively clear amyloid. On one side, lecanemab. It's an IV infusion every 2 weeks, and its trial showed a 27% slowing of clinical decline over 18 months. On the other side, donanemab, given monthly via IV, which showed up to a 35% slowing for low to medium tau patients over 76 weeks. Both yield massive reductions in amyloid burden, which is a monumental first in clinical neurology. We're literally modifying the disease trajectory now, not just treating symptoms.
And finally, Section 6, ARIA Safety and Management.
Now, as amazing as those therapies are, they come with some intense safety caveats regarding ARIA, or amyloid-related imaging abnormalities. Seeing these side by side is absolutely critical. On the left, area E. The E is for edema, and you can clearly see the focal cortical swelling on that FLAIR MRI. On the right, area H, with the H standing for hemorrhage. That T2-star MRI shows potentially devastating microbleeds and superficial siderosis. Honestly, about 75% of these cases are asymptomatic and only pop up on surveillance imaging. But we have to be hypervigilant because they can escalate into severe seizures or stroke-like episodes. Because of that, we have some very strict safety and management protocols. If you take away just one clinical pearl today, make it this. You absolutely must genotype for ApoE4 before starting treatment. There's an FDA box warning on this because ApoE4 homozygotes have the highest risk of severe recurrent ARIA. You also need to run multiple surveillance MRIs during the first 6 to 12 months of treatment. Oh, and this is an absolute contraindication. If a treated patient presents with acute stroke symptoms, get an MRI immediately to differentiate stroke from ARIA. Do not administer intravenous TPA. It is strictly, absolutely contraindicated because of the massive risk of fatal, catastrophic, multifocal hemorrhaging. All right, as you digest all of this dense postgraduate review, I want to leave you with a final provocative thought. We are living through a historic pivot in medicine. As Alzheimer's disease transitions from this inevitable clinical decline to a biologically treatable reality, how are you going to integrate these advanced biomarkers and stringent safety protocols into your own daily clinical practice? It's a rapidly shifting bench-to-bedside paradigm, and it's going to completely alter neurology over the next decade. Thanks for joining me on this explainer, and keep exploring these medical frontiers.